time? Perfect. Okay, so welcome to everybody. I have the privilege of starting out this meeting in my new role as primary care lead, which I'm still growing into with a bit of comfort, but wanting to make sure that we acknowledge Camilla Singh and her work in getting us going with all of this. Yesterday we had Orange Shirt Day, and I'm just thinking about in this setting the long story that we're coming up to today. Indigenous peoples for many years who for so long who looked after our land, and many of us are very grateful for their involvement in how they shaped our land, and the sharing that we were able to have. And then in the 70s, public healthcare started. This is a huge jump here, right? Public healthcare. And then a bunch of decades ago, the docs in Cambridge were beginning to work together and what they were doing. And more recently, the OHTs coming in and being an initiative to draw organizations and agencies together in looking after healthcare. And now, in the last couple of years, we have the primary care networks that have been encouraged by the government to be a part of Ontario Health Teams. And so what we're talking today is supported by your primary care network, but also by our OHT. As we talk about applying to the interprofessional care primary care team round 2 applications of proposals for expanding primary care, getting it to work together better. And we did our best to get as many people connected as possible today so that they could get this information and get thinking about what it is that the government asked of us. So that's where we're starting. And our team has put together these slides, and Lindsay is going to go through the slides and give us an idea of what's being asked in this round of request for proposals. So Lindsay, are you all right if I hand it over to you?
Absolutely. Okay. Hi, everyone. For those that don't know me, my name is Lindsay Byerman, and I am on the staff support team with the Cambridge North Dumfries Ontario Health Team, and I'm supporting this IPCT round 2 application alongside our PCN. So thought about going through some of the foundational information that we have here in Cambridge North Dumfries. So by ways of the primary care landscape in Cambridge, we've got 2 family health teams, so Grandview and Two Rivers, 1 community health center, of course, Langs, 1 nurse practitioner-led clinic, so the Waterloo Region Nurse Practitioner-led Clinic. We also have 8 family health organizations and a handful of solo practitioners in our community. And when we're talking about attachment to primary care, it's important to get some numbers here. So in Cambridge North Dumfries Ontario Health Team, we have a total attributed population of about 164,000. And when we're talking about attributed population, that is really speaking to those that seek healthcare services in our community. So it's slightly different from the census population, but comparable. And the total number that we have attached to primary care in Cambridge North Dumfries is about 147,000. So that means we have just shy of 17,000, or about 10% of our population, unattached to primary care in Cambridge North Dumfries. And we have a total of only 16 people on our local Healthcare Connect waitlist. And so the Healthcare Connect waitlist is that provincial number website that you can connect with to ensure that you get primary care. So we have a whole lot of people in our community that are not necessarily on our radar, but in need of healthcare services in this community. So I'll pass it back to Craig just to talk a little bit about the work of the primary care network in our OHT.
Sorry about that. The primary care network is an opportunity. That's kind of where I see it for those of us who are doing primary care. I have been working in Cambridge for 15 years, and we've had lots of work on our system, thinking about mental health pieces or thinking about surgical pieces or whatever. But when we talk about uh, planning of the system, primary care has not always been directly involved in the table. We have had support from our administrators and from other folks like the Lynn who have kind of looked out for us. But um, at this point, we have a primary care network where we actually have a place at the table to shape how care should look, which is a big opportunity. So it's a model to bring docs and NPs together throughout the community, throughout our OHT, basically, and to make sure that everybody has a voice who wants to have one. The goal is to tailor our healthcare to local needs, trying to improve access, working together as teams, and then coordinating with our larger organizations like Ontario Health at Home and CMH and the like. This primary care network is run and supported by a primary care network leadership committee, a few primary care folks who have committed to being a part of the ongoing discussion, meeting monthly. And so we're backing up some of this work for the proposal, but it'll be also a longer term things, making sure that primary care needs and issues for our patients are addressed and coordinated. So this is kind of a plug if you're here listening and you haven't been involved to kind of learn a little bit more of who to contact and how this is working. We have sort of different levels of membership, which doesn't really mean a lot. At the bottom there, you see that we have 45 docs and 4 NPs who have membership, but we do have 99 practitioners, maybe more. Surprisingly difficult to figure out who's here and working in Cambridge because all of us have worked in different models or worked independently. So if you know people or if you haven't been connected with the primary care network and been a part of that membership, please make sure you connect and make sure we at least have your contact information.
Great. Thanks, Craig. Okay, so getting into the IPCT round 2 application. So this is round 2. There have been 2 previous rounds, which have been referred to as round 0 and round 1, with round 1 occurring earlier in this year, specifically looking at high needs forward sortation areas, or those first 3 digits of a postal code. So our OHT was not invited to submit an application in round 1. So we are looking forward to submitting something for round 2. This IPCT application process has been launched by Ontario Health. So it was launched on September 22nd, and applications for this are due on November 14th. Each OHT has been told how many applications they can submit, and specifically here for Cambridge North Dumfries, we can submit 1 coordinated application. In this round, there's $250 million available with the intent of creating 75 teams and attaching 500,000 patients. And this round is part of the government's overall plan to spend a total of $2.1 billion to expand or create 300 new and expanded primary care teams and attach 2 million patients by the end of 2029. So round 2, the results of this round will be announced in spring 2026. So the emphasis on this application is really about expanding or creating net new team-based care. And I actually have expanded, highlighted, or bolded there, because really we are strongly being encouraged to expand existing team-based care and present a coordinated approach to support access, attachment, and enablement. And so the strategic evaluation priorities for this application are going to focus on primary care attachment. So how many net new ongoing primary care attachment spots can we commit to in this application? There's also highlight of readiness to implement. So the ability to be operational and begin attaching patients by spring 2026. and overall meeting primary care objectives that includes supporting connected, convenient, inclusive, empowered, and responsive primary care in our community. So I can't reiterate this enough. Attachment is the main goal for this application. Getting as many people attached to primary care as possible in our community. And we have to be explicit in this proposal about how many patients can be connected through this proposal. And this, a couple of highlights in this application of things that are being asked of us. We are going to be asked to identify interest in establishing a primary care teaching clinic. It's not looking for a formalized partnership at this point, but just a general interest in pursuing this option. We are encouraged to use the primary care action team or PCAT data package that's been provided to all OHTs across the province. And that gives us an understanding of our unattachment available by different layers. So forward sortation areas, ADAs, and census division. Funding for this application is available for the following: salaried physicians, NPs, physician assistants, interprofessional team members, so think social work, RNs, RPNs, physio, respiratory therapists, etc., administration and management. An identification of partnerships and letters of support is encouraged in this application. We are asking those interested to complete this short survey by Monday, October 6th at 5 p.m. And this is very quick. This will take less than 5 minutes, but really just trying to identify which clinicians or FOs, practice groups are interested in supporting this application. We will pop the link up in the chat momentarily. The CND Primary Care Network will be reviewing interest alongside the OHT. And the next step in this process will be a planning discussion planned virtually on Thursday, October 9th, so a week from today, from 7 to 8:30 p.m. to discuss the approach. I will say that this is just one opportunity to be engaged in this work, and then would encourage anybody who cannot make the virtual discussion next week to reach out to Dr. Albrecht or myself to keep the conversation going and be included in this planning. And that concludes the end of the formal presentation today. We wanted to make sure that there was tons of opportunity to ask questions. We'll do the best that we can with the information that we have, but this is sharing just a high-level overview of the information that has been provided to us by Ontario Health. Any questions that we can't answer, we will take it back to Ontario Health and try to get answers for the group today. So with that, I'll open it up. Any questions, comments about the IPCT application or the approach in Cambridge North Dumfries? Debbie.
Yeah, I had two questions. My first question is the survey. Is it one response per organization, or can several people complete it from an organization? That's maybe I'll let you answer that first.
Yeah, several people can answer. We're really just looking to get an understanding of who's interested. It's not a hard and fast expression of interest. We just need some names, know who should be involved in these planning conversations going forward.
Okay. And then my second question was around the data. Do you have data to show where these unattached people are located right now so that we can do effective planning?
Absolutely. And so that will be a priority in this application. So I did mention the PCAT data package. There are 3 different overlays of the unattached data. So that is available by forward sortation area, census division, and ADA. So we do have a good sense in the OHT where these unattached people generally are. Dr. Gupta. Oh, you're muted.
How do we plan to expand or get a new FHTs? Are we trying to convert FHOs into FHTs? And because we have only 2 FHTs and, as you say, 9 FHOs. So are we planning to amalgamate everything and create 3 or 4 FHTs? What's the idea?
Greg, did you want to take that one?
Sure, it's a good question. The proposal doesn't tell us what we're supposed to do. They just say what we could do. So things like you could create a brand new CHC or a brand new family health team, or you could make a FO into a FIT. What we've heard from from Ontario Health is that they're not likely to approve a brand new family health team or a brand new CHC. They're more likely to approve connections between us. So maybe an FHT or a CHC would be able to affiliate some FOs. The language is like way open to interpretation on how that relationship might work, but the idea is we're more likely to get it approved if one of our larger organizations kinds of suggests expanding, providing funding, providing services, and then the FOs, those 8 FOs in our town who are not connected to a FIT or to a FIT, then could get more services, whereas the FIT and the CAC might have some of those services already. Does that make sense?
When we are giving them in writing our plan, our requirements in the IPCT, so should we not mention there that this is how it should work for us, rather than letting them do what they want to do and people may not like it? So should we have a plan in hand to give them in writing? Okay, so this is our plan. This we want whatever we decide maybe in the next meeting, that okay, we want more staffing for the FOs, or if you want to amalgamate all the FITs and the FOs and make 3 or 4 FITs. That's how it works. We have to talk to people. Maybe the FOs are not ready to do that, or we can simply add some staffing to the FOs, so which can make them work better.
Right. So those are all good ideas, but they only have given us one application in our OHT. For example, Kitchener, I think they can apply, they have 4 applications they can put in because they have more unattached folks. So we only have one, which means we have to work together to figure out what we're going to ask for. So they won't necessarily tell us. That's why we're having this conversation today for information, and next week to talk a little bit further so we can shape what this looks like. And hopefully people who want to be in on it can actually be part of that discussion, which is kind of a new thing. These rounds of requests for proposals have come out before, but primary care and the primary care networks have not been as much involved. So this is actually a good opportunity, but it means we're going to have to show up and we're going to have to work together.
Oh, that's great. I appreciate you taking the lead in it. Yeah, so maybe we need to talk at more, like we did try talking to the people at personal level, and I don't think we end up getting much feedback from them, if you remember.
Yeah, so the primary care network did send out committee members to different groups, and we tried to collect that information. But the difference was there that at the time, we didn't really know what the government was saying when they were going to request these proposals. When this came out a week or 2 weeks ago, we suddenly had to say, okay, well, this is bigger. They're actually asking for bigger proposals than what we had initially thought. So we need to make sure that everybody's involved, and we need to kind of go around that circle again and say, okay, now that they're being a little more clear about what we can ask for, we should get together and chat.
Okay, but can we tell people, okay, these are the 3 things available, pick what you want?
Yeah.
But
so today was just information. We just want to make sure that people know what's out there. And then on Thursday we can keep talking, and then the PCN will probably put together 2 or 3 different options so that we can actually discuss it and be more clear. Does that make sense?
No, that's perfect.
Perfect. Shall we move on
yes.
Who was next?
Chris?
Yeah, thanks, Craig. Is there any further direction on how much money is given per attached patient? Is there any kind of correlation of that information yet in terms of you shall get this if you attach that? Will that come?
Unfortunately not, and we likely will not get that information. So that's why we have to put forward a strong proposal to show a strong attachment across Cambridge North Dumfries.
Okay. So we kind of have to ask for a certain amount of money and then assimilate what that might mean in terms of how much of our percentage of unattached 16,000 we can do, like 8 or 9 or 10 or 12 or whatever, right?
Yeah, and I think it'll be important in this proposal to go as big as possible, recognizing that we may not get as much, and have a contingency plan in place.
Okay. Okay. Thank you.
Okay. Dr. Halling.
Thank you. So I kind of wrote down a few questions here to consider. My first is a little bit similar to what Chris was saying, but more in a sense of in our collaboration with other organizations, can we find out? So we know KW was able to get 4 applications. You know, how many people do they have on their clinical connect waitlist? Like, can we get sort of a comparable number so we can understand a little bit better what the ratios are that they're looking at? So I'll let you answer that first before I go on to my other ones.
So I know in KW, I believe it's about 80,000 that are not connected to primary care, and they too have low numbers on their Healthcare Connect wait list. I'll let anybody who's with KW4 fact check me on that, but that's what I had been told. I see a thumbs
That's
up.
interesting. So they are looking at more than just Healthcare Connect when they were trying to determine those numbers. Hey, that's the basic idea. Okay, good to know. Okay, so then our great efforts of trying to show them how we actually have 16,000 is still not going to get us very far. So I'll stick to the one application idea for now. And then I guess my other question is actually putting it out to the whole group. I would imagine sort of early in our process as we try to put together this plan and proposal, we would want to know with the 3 sort of big groups in our city, so the 2 family health teams and the CHC, you know, if they actually have office space. And I think that's what you've put out there in the questionnaire, but I think that will be a really, you know, we want to kind of hit the ground running as far as knowing what is even options available as far as space goes. If we have to put it all into one, it's unfortunate because I feel like it's a bit too much of a burden to put on one team. But maybe this is just the first time that we get an opportunity, and then the next time we can share and you know, utilize resources from one of the other teams. But yeah, just kind of putting it out there that it will be nice to know from the main teams who has space so that we can get started.
Yeah, for sure. And that's why in the EOI, we're asking about space. It was very clear on the technical webinar on Friday that capital costs are not to be considered as part of this application process, and that is a separate pathway. Hence why there was a strong emphasis on expanding already existing team-based care. Dr. Pignelli.
Yes, hi, thanks. Craig, I appreciate you actually partly answered my question already about saying that you'd been out to the community and to the different groups when there was not a lot of information available, and now there's more available. I'm just wondering about the level of engagement we have from the physicians who do not currently have these services. Because to me, the crux of the application is, okay, doctor, how many more patients could you accept if you had services of the fit that you currently do not have? And then how can we provide those for you and where and all of that? So I think it's really important that we have a chance to reach out to all of these folks to ask that question, because either we're going to need physicians who don't have the services to indicate what their increased capacity would be like if they had the services. And then we need to also ask the various groups that are FOs, because I know one of the stumbling blocks, it's a bit of a catch-22 if you're trying to get a new FO physician, you can't get the spot secured until you already have a candidate secured, and they might not want to be secured if they're not positive there's a FO spot. So a guarantee of some additional FO spots, because those new doctors could automatically take 1,000, 1,200 patients each. It would be very helpful, I think, to also ask the existing FOs or other groups who have space available in their facility who can take more doctors. And if we can roll that into, because I know our ongoing recruitment efforts across the board, but if we could roll that into this application and also to say, what would make it more attractive to be able to recruit those physicians, that's a lot of additional patients that we can take. So I guess I'm just wondering about what else we can do or are already doing to reach out and really get a sense from our community doctors about what the needs and availability are like.
It's a good question. And I think that's why I see this as an opportunity really for us to connect together. And I'm hoping that everyone on this call will sort of pass on to the other people that they know that this process is going on. Because I've connected with some of the groups, but maybe just the lead physician or the lead whatever, and then it's up to those providers to show up on a session like this to really understand. So pass out the news, tell them this is an important thing, and number one, we can put together a proposal that works for all of us better if there are more people involved. But number two, once you get connected, maybe we can learn some of the other pain points and the other challenges that we need to work on even after this proposal goes in. Speaking about some of your comments about the numbers of people that we can take on. For this proposal, we definitely have to make all of our items as we propose connected to how's it going to help us attach more patients? And I know there's lots of us out there who cannot take on more patients because they're doing as much as they can. So what are the things? So we're kind of looking at two levels. We have some groups already who can take on patients simply because they have new docs and they are already taking on patients. And maybe we might have capacity for 1,000 or 2,000 to be taken on without any new resources, because that's kind of where we sit at this moment in time. But then with more resources, what else can we add on top of those things? So, and then that kind of follows in, like, should we ask for organizations to be able to recruit new people to jump that number up quickly? But secondly, what are the services that could be provided by a kind of a central organization in this proposal that will help offload the efforts that each of the docs and NPs are doing to maintain patient care? What are the things that might make it easier so that you could take on more patients? Does that make sense?
Yeah, that's exactly how I see it. So, Craig, if there's a bit of a hit list or any key people that you see, like surveying the community and the physicians that are here, if there's anybody in the hit list that any of us can help with, maybe people have connections with some of these doctors, I think it's just really important that we hear from them, because as we're putting together an application, if they don't know about the meeting or we don't know that they have space or interest, we're not going to have much to put in the application. So if there's a way we can coordinate, like reaching out and trying to get them at the meeting, I think that all of us could help with that. If you have a email list that you can circulate or a few targeted people that we can try to get there, I think that that's really necessary, or we just won't know where the capacity is.
Totally agree. That's kind of why we did this stepwise thing. Like, today's just information. Next Thursday, October 9th in the evening is more of a discussion. So hopefully we'll sort of be like a snowball that just continues to grow up, and more people can connect and make sure that they know, because some of what I've heard in the community is, you know what, nobody ever told us that this was happening in this proposal, and they've got that and we don't have that. So the more people we can get connected, the more equitable we can make our system for the patients in Cambridge.
Yeah, thank you. That's my questions.
Jennifer?
Thank you. I was just going to follow that up with, we did as a group fan out to as many primary care offices and practitioners as we could 2, 3, 4 months ago. And I think we have a Google Doc that's still, we collated some of those discussions. We weren't at the point we are at now. So, but to your point, a lot of people didn't, and just even making that connection was very, very helpful. And I know from the groups that we met with, they were kind of maxed out, but would have really appreciated some wraparound care. So that's a little piece there was. Lindsay, clearly the focus here is to attach patients. That makes perfect sense. Is there an understanding from the community attached and currently attached patients in Cambridge North Dumfries of what their needs are on a like sort of macro level? What I mean is like congestive heart failure, diabetes, et cetera, so we can think about what kind of wraparound care would that information be helpful to support our application as we say, we are requesting, we have these unmet needs in these really significant areas of chronic illness. What would you say to that?
Yeah, absolutely. So we will definitely be including that in our application to show the high needs in Cambridge North Dumfries. We know that we have an aging population. We have a complex population. We have high incidence rates of chronic disease. So anything that we can show to demonstrate the need that we know exists in Cambridge North Dumfries will only help to strengthen our application. Donna.
Hi, thank you. I just wanted to mention that over the past, I'd say 2 years, I've been approached by so many new walk-in clinics that have popped up in Cambridge, run by either real estate agents or pharmacies, wanting me to put them on my list of physicians accepting patients, even though they're also walk-ins. I do because it is a doctor that's in town accepting patients, but I haven't toured any potential physicians to these locations because I'm not quite sure of their models. So I'm not sure what your feelings are about that if you want me to reach out to any of them. Most of them are the UK docs that are trying to immigrate over to Canada. It's been hard to place them with our foes because people don't want to go through the LMIA process and then also bring in a physician who they haven't locumed and got to know, that type of thing, because we don't know if they're staying around. From my network of physicians across Southern Ontario, I have found that some of these physicians do come into a community because they're placed here by a professional recruiter, not a community recruiter, who is paid to do so and place them in a community, and they sometimes don't stick around more than a year or two. So I've been walking a really fine line with all these walk-ins that have been contacting me in the past. I didn't know if you wanted to know about them, or I'm not sure how you want them to be included or not included.
That's a good question. I don't know if Lindsay, if you have something to add to it. I think it's worth understanding how many of those groups there are and how many, like what sort of things they're looking at. So seems to me to have, if they want to be a part of the conversation as we work together, that would be a good thing, right? And that's the conversation within our community to make something that works for all of us is going to benefit our patients. If there are clinics who have their own goals, we may not be able to meet those own goals, and we may not be able to sort of support that, in which case I could see that not necessarily working out. But it would be helpful to have the information. So if you have any, please send them off to me.
No problem. Thank you.
We do definitely have some sight lines. Again, we've been talking to you, Donna, about this, and we so appreciate you flagging this. From an OHT perspective, we have reached out to them to let them know that we're here, that there's a primary care network, with the hopes of enticing them to stay and become permanent members of our community. So we continue those efforts, and I think the more welcoming and inclusive that we can be for this, the better. So we'll continue those efforts, and we'll work with you on that. All right, over to Leanne.
Hi, everybody. I guess I have one quick question and then a comment. First question is if the MPLC data is included in those on attachment numbers, because I know that it's tricky to capture our data. So that would take thousands of people off that list if it wasn't. And if it is, then it is. Second, I think that it's important with this. We've been through 3 rounds of this now, the MPLC. No, actually 2. One was unsolicited, but we were approved in all of the rounds that we've applied for. So I think, not reinventing the wheel and perhaps taking, pain points and learning curves and everything from those of us who have been through this already, what OH is looking for, what they're not looking for, what they don't care about, what they do care about. And I think not underestimating, I know we talk about like the bigger organizations, but not underestimating the MPLC's role in this. We're currently building a big, beautiful, brand new space. So, in a year from now, we'll have a different sort of capacity there. But I think, more than happy to share our learnings from doing this. It's, we're gonna ask for something huge. We're gonna get something small. That's just, it's not a lot of money when you think about all of the applications that are going in. So how do we maximize, our current resources, our current partners, and put in a proposal that they'll look at and say, you know what, this is cost effective. It's going to attach a lot of people, and it can, we can start tomorrow. We don't need to go out and beg people to come work for us because we've already got XYZ lined up. So Krista and I, as I said, have been through this now twice. So more than happy to share sort of, what we've taken from it.
I'll just jump in really quickly about the data. My understanding is this latest round of data that we have does include NPLC and the CHC. And then I'll flip it over to Craig if he had any comments on the rest.
Yeah, I just was going to make the comment in terms of attachment. It's interesting that our proposal is due November 14th. And it asks us to say how many patients we will attach by spring 2026. And the approval for the proposal was, did anybody catch it? Spring 2026. Interesting, huh? So it tells us that like, that's the kind of readiness that they're looking for. So like if they say, yes, you have it, then we start attaching right away. And in our case, it may simply be, we start attaching in those practices that are already set up to be attaching. So that can be at least a little, the early start, and then we'll have to quickly ramp up from there.
Dr. Holling.
I was just wondering, I would imagine since it's one proposal, the money will have to go to one organization, just kind of thinking logistics. I wonder within that though, are we allowed to kind of just share that all over the place, right? So let's say whatever the MPLC decides they're going to be the money holder, or Langs decides they're going to be the money holder, but we've got a social work hanging out in Two Rivers, and we've got a physio that has some spot over at Delta Pho, and we've got like, is that an option? Can we have them all shared all over the place, even though the money comes from one place?
I'm hoping that Lindsay can answer that. I think kind of yes, but kind of no. But Lindsay, you go ahead.
Yep, to the best of our knowledge, that is the case. I was looking at Leanne, who's been through this process, and she was nodding her head and has responded in the chat as well. So yeah, that's what we believe to be true in this application round as well.
Jeff, can I butt in front of you just to kind of, because my comment goes with that one. Thanks, Jeff. So hi everybody, I'm Krista. I also am heavily involved in the PCN on the KW4 side. The one piece that I was going to say in terms of like lessons learned and that piece of the money, and especially for the FO and single shingle folks, is to really understand where the limitations of the transfer payment agreements are, because I can't tell details, but there was some serious limitations in the FitFO applications in the KW4 for the last one that led to some significant changes post. So just making sure that if that ties into what we end up applying, just make sure that there's a clear understanding of what their plan is this round, because it changes a little bit every single round. Thanks, Jeff.
Thanks for sharing that, Krista. And if you don't mind, maybe we'll reach out just to help us navigate that piece and figure out how we can apply that in CND. Okay, over to Jeff.
Yeah, I'll jump in. It's Chris. Craig, Lindsay, thanks for taking this on, doing this. I know it's a big task. We're going to ask if we were to have some space in our building, just trying to find out in terms of like funding, is there funding for making the rooms with that worked for exam rooms, say, is there funding for that kind of thing? And then ongoing, like if we were to start a clinic here ongoing, does the government support that clinic ongoing, or is this a one-time funding, you guys get it going, but who's paying for it as year 2, year 3 goes, things like that? Is there any word of that kind of thing, Lindsay?
So I can speak to those points. So our understanding is, while capital costs are not allowable, expenses related to modifying existing spaces are. There's more details in the application, but that isn't an allowable expense for this. And in the technical webinar, they indicated, Ontario Health indicated that this is not one time and would formally enter into an agreement with the Ministry of Health for ongoing operating. That has been the messaging that we have received as part of this application. Okay. Dr. Kavanaugh.
Two questions. One is, has anybody done any research on how many of those 17,000 actually want a family doctor? That seems to be a pretty key question. What is the percentage across the province who won't sign up even when they're offered a family doc? And I know those patients exist. They're quite happy with going to walk-ins, convenient walk-ins, and don't really think they need a family doc. They don't need an longitudinal record. So that's question one. And by the smiles, I gather that we don't know that number.
Mm-hmm.
Yeah, I can speak to that really quickly. So while the province is advancing 100% attachment for everybody, the messaging that we've been using within our OHT and specifically the PCN, 100% attachment for those that want to be attached, because we recognize the realities of day-to-day being formally attached to a primary care provider in this community may not suit your lifestyle. Unfortunately, we don't have any sightlines on that without having some sort of like patient level data, and short of calling up every single person asking them if they want a primary care provider. So we will continue to attach as many people as possible, recognizing that we may never get to that 17,000 completely in this community.
Okay. A comment and then another question. The comment is that those patients who don't need to see doctors very often are actually very popular amongst the foes and fits, because they add to our numbers but don't add to our workload. So getting those low impact people signed up to someone is a lot easier job than getting a lot of diabetics or advanced seniors signed up. Now, next comment, as a retired FO guy, I think the biggest question for the 8 FO around and the doctors who work there is what's possible. Most of them don't have the bricks and mortars to give an extra room or two to any help, a nurse practitioner who we might be able to hire to help handle some of the load, or any of the ancillary healthcare people that might help us. So what's possible, I think, is the biggest question that'll be in people's minds. And once they know what's possible, then they can comment in a more practical way on what would work. If we make more space available at Grandview, how could that actually work for a patient who's assigned to a FO doctor out in the community with a clinic with no extra space? So possible work things, I think, would be the number one question I would ask if I was still practicing. How can you help? And what are you willing to do?
If I can just answer that, thinking about what's possible and also thinking about like how that possible is available to as many people, as many of our folks in Cambridge as we can, so it's more likely that this application will be successful if we're showing that it's not just putting a service in one clinic, but putting whatever service it is will be more available. And there's lots of different ways of positioning that and saying that, but worth just paying attention to the possibilities of a more central type of a solution where folks come to from various practices, rather than sending the outcomes of the funding that we receive and just plopping them in the many, many different locations we have. We have 8 FOs, but there's actually 2 more under the family health team. So it is 10. And we've got to keep in mind all of those. And some people aren't even in FOs, and it makes sense to think about patients regardless of where their attachment is. One other thing I want to add, just based on your question about who wants a doctor. So we could just walk away from that question about attachment, because we have, like, as of last January, we had 17 people on our Healthcare Connect list. So that's the government list that people are supposed to put their name on, but nobody has, because they never went anywhere, and it was too hard to get your name on the list. But now they're starting to rely more and more on that list. So as an aside for what we're talking about here, it may be worth many of our practices to think about how to get the patient, like amalgamating the wait lists that we may have in our own clinic onto that Healthcare Connect list, so that we can actually do some planning, rather than sort of trying to be good citizens and saying, well, let's try and attach all those 16,000 people when maybe they don't all want to be attached. So there's that 16,000 who haven't put their name on the list, and there's the 17 who have, and there's our numbers somewhere in between. And the OHT has been working on getting people to sign up on that list, so we actually know what to do with it.
And Craig, I'll just take on to that as well. We have been working closely with our healthcare connector assigned to Cambridge, and there is a willingness from her to reach out to the practices and help support that wait list that you might have, and help manage it, so so that we can get better sightlines on what the needs are in the community. And Chris, over to you.
Just to build on James's question and Craig's answer too, many communities in the province have a similar model to what Craig mentioned, where Barrie's a good example, where they have over 100 doctors as part of multiple FOs and all connected to the family health team. But they have one big site that's pretty central that has a lot of these IHP services that the community doctors can send their patients to, because it's a very big challenge to have 2 days of social worker in one FO or one clinic and another day over here, and then one health promoter day. And so they kind of amalgamate them into one central location. And then any doctors can send their patients for these resources of social worker, respiratory therapist, occupational therapy. So I just know that really works well in many other communities. And yeah, so that could be obviously one good option.
Very much. Just looking at time, we are coming up to 1 o'clock, so I'll pass the last question over to Donna.
Yeah, I just have a question. I had a meeting yesterday with Jane Tillman from Ontario Health and the new advisor for the area. And the one thing, again, talking about Healthcare Connect, an issue I've had for a long time is they won't tell us how many doctors are actually signed onto that list. So say no doctors in town are on it, and we're directing people to it, it's never going to be fulfilled. So that's, I know there obviously are, because we did clear the list recently, but I asked her why they will not tell us the doctors who are on it, and she didn't have an answer for me. So again, I don't know if you're still working on that or if that could be.
Yeah, so I can confirm that the OHT continues to work with our healthcare connector to get a sense of the numbers. So we have requested that multiple times, and we actually have a meeting with our healthcare connector on Tuesday, and you can bet that will be top of the list. So we'll share that information. Thanks so much. Okay.
All right. Thank you to everyone. This is a really good discussion, better than I expected, because we were able to get our information there, and there's tons more to read, I'm sure, and many more facts you need to get straight in your head. But really good questions about, like, why is this, and what are they asking for, and what should it kind of look like? And so please reach out in the meantime if you have questions and specifics about what you're thinking. But also, please pass on that information to as many people as you know for October 9th, so that people know that, look, this is your chance to sort of shape where things are, and you will be heard on this, and you have an opportunity to be a part of something that can shape stuff for the patients. Like as a doc, when I see patients, you guys know the impact of looking somebody in the eye and saying, you know, there's just not a resource for that. I just can't help you. I don't know what I do. Or yeah, you're going to have to go to Kitchener and you're going to have to take the bus and it takes an hour and 40 minutes. And if you don't go, you're not going to get it. So this is our chance to sort of work on some of those things that get so frustrating in our practices, and to get help with it in some way. It's not me giving the funding, it's not the OHT giving the funding, it's the province, but at least we can work together at getting somewhere. Does that make sense? Lindsay, do you have anything else to add?
I just want to thank everybody for their time today. And just as a reminder, please reach out to Craig or myself. Email addresses are in the chat if you have any additional questions or would like to talk about next steps in this process. We've got the link to the EOI, and we've sent that out by email. And Brenda had just put a reminder in the chat as well that registration is required for the October 9th meeting that is happening virtually from 7 to 8:30. So please register if you would like to participate in that planning conversation. But again, just a commitment to openness and willing to talk through all of the possibilities about how we can best support primary care in our community in attaching people.
Right. So everybody, you can't just find the link at the last minute and jump in. You have to register. So tell everybody that, because when people are madly like, where's the link? Where's the link? Well, you need to do that. So please connect. Thank you, everybody, for all the excellent questions and for your attention. Have a great day, and we'll hopefully see you next week.